year, we were an actively licensed adult day health care program. We are one of the first 5 programs that started in 1975 in the state of California. Earlier this year, the Institute on Aging Board of Directors made the painful decision to no longer offer adult day health care through our agency. This decision was made in late March and officially announced to program participants and their families on Friday, April 1st, of this year. June 30th was scheduled to be the last day of ADHC services. This allowed our staff 3 full months, 3 months, same as the transition plan, to assist our participants and their families in finding alternative services. At the time of the announcement, we had 72 Medi-Cal participants enrolled in the program. During the 3-month transition program period, 1 participant was placed in a locked psychiatric facility and another was tragically killed. Our plan was to encourage as many participants as possible to enroll in a PACE program. Immediately, however, we found a number of our participants would not be eligible because they were either too young or had a primary psychiatric diagnosis without significant medical diagnoses. We also had quite a few participants whose dementia was so advanced that they are already considered nursing home eligible and would be considered a high risk by PACE. Of those who were potentially eligible, we encountered a number of reasons for declining a referral. 1, the IHSS hours a family member received were literally the only source of income. 2, the participant had a long-standing relationship with his or her medical providers and was reluctant to change. And 3, the participant lived alone and needed an overnight caregiver, something that's not provided by PACE. When we closed our ADHC doors on June 30th, we had enrolled exactly 2 people in PACE programs, with 3 more pending enrollment. Many of our participants self-referred to other ADHCs, and our social work staff also did refer participants to other ADHCs. In general, these were participants who would not be eligible for PACE or had refused a referral. There were a number of participants who referred to home. This group included those with advanced dementia and the maximum number of IHSS hours, and participants who, upon our assessment, seemed to have enough services in place to maintain them in the community. I've got 5 quick scenarios. I'm going to tell you about 5 participants, what actually has happened to them. Participant A fell into the latter category of having a lot of services. Her diagnoses included schizophrenia, diabetes, hypertension, osteoarthritis, and peripheral vascular disease. She was on 8 oral medications and a biweekly injection of psychiatric medication. She lived at home with her son as the primary caregiver. She attended adult day health only twice a week. One of her main problems was the voices in her head telling her not to do things. Sometimes these things were innocuous, like don't drink green tea. More often they were very serious, especially when the voices told her not to take her medications, that they were poison. While she was attending ADHC, we enrolled her in our agency's medication oversight program to help her with reminders to take the medications. She attended the program twice a week, and on those days she not only received services from the program nurse and the occupational therapist, but also the social worker who met with her regularly to provide support and reality testing regarding the voices she heard and what they would or would not allow her to do. She had been attending ADHC for a little over 2 years without a hospitalization when she was discharged in June. Our MDT, multidisciplinary team, decided a discharge to home would be most appropriate given the amount of services she had already in place. And I'm going to tell you what they were. There was 100 hours of IHSS a month. There was Meals on Wheels, 7 days a week, 1 meal per day. She had a community mental health counselor she saw once a week, a community mental health nurse practitioner she saw every other week, a community mental health peer counselor she saw once a week, a rep payee, the medication oversight program through our agency's friendship line, recent APS involvement, although the case had just been closed, and she was a member of the San Francisco Health Plan, our county managed care plan. We received a telephone call on July 21st informing us that this person had been hospitalized for psychiatric reasons. The only thing that had changed for her was her discharge from the ADHC program. Other participants we've heard from, they're a little bit quicker. Participant B's daughter was able to convince her community mental health day support program to let her attend 1 extra day to 3 a week. They only operate 3 days a week. While she does have a psychiatric diagnosis, she also suffers from moderate dementia. The program there is not secure and is staffed differently from ADHC. The participant has since wandered away from this program multiple times. Her daughter has her on the list and is waiting for placement in the county nursing home. Her comments are, I can't take it anymore. There is overwhelming literature that cites caregiver stress and burnout as one of the primary reasons for institutional placement. Participant C was discharged to home. Her home is a board and care facility. She also has diagnoses of Parkinson's, schizophrenia, Alzheimer's disease, vascular dementia, diabetes, hypertension, and osteoarthritis. She also has a community mental health counselor and psychiatrist she sees approximately 4 times a year. Her Parkinson's disease is so severe that she is unable to feed herself and requires high levels of care at the board and care. She had been attending ADHC since 2005. Her psychiatric symptoms had been stable, and she had no decompensations or exacerbation of symptoms. In a recent conversation with her board and care operator, we learned that participant C has become very emotionally unstable. She is screaming at everyone in the home and is now in grave danger of losing her housing. Because of her high level of care, it is unlikely that she will be accepted into another board and care facility. This participant and others like her are trapped in their own homes and isolated, essentially institutionalized within their homes and without interaction from the outside world. Participant D was receiving chronic wound care at the ADHC, while also on a behavioral contract for the management of challenging behaviors exhibited both at the center and at home. To ensure she received wound care during the transition period, the participant's case manager with our San Francisco Community Living Fund arranged for home health to provide the care. The participant was given a hard and fast 2-month limit to find a long-term solution. The case manager has attempted to enroll her in another ADHC, but most are now declining because of her behavioral problems. This case manager stated that home health is not able to manage chronic wounds, and this is an issue with many of her clients. She said that the wound clinic or outpatient care is not a viable option for most of these clients, including participant D, because of transportation and scheduling issues. There is currently no plan to manage this participant's wound once her home health is discontinued. She has spent a number of years at Laguna Honda Nursing Facility prior to being discharged to the community for her care. And finally, participant E lives alone with 126 hours a month of IHSS. She also has an MSSP case manager. She has Alzheimer's disease, glaucoma, she's just about blind, diabetes, hypertension, osteoarthritis, and a history of falls. Just prior to the closing of our Adult Day Health Center, our staff had been working closely with the MSSP case manager to get this participant back into the program. She had stopped coming because her legs were hurting so badly. The case manager was able to find out that the pain was being caused because the IHSS workers continued to administer a medication that the doctor had discontinued, despite repeated instructions from the case manager to discontinue this medication. We were trying to get her back to ADHC so that our nurse could remove the discontinued medication from the Mediset per the doctor's orders. Then our centers closed, and we were no longer able to work with the case manager. The participant was left at home with the intermittent IHSS and still getting the wrong medication. Since then, the participant has fallen and has been hospitalized. We believe that if we were still providing services, we could have had her come back to ADHC or had our nurse make a home visit to rectify this situation before it became this costly and painful problem. Including participant A, who actually contacted us, this sampling represents 50% of our participants that we just recently contacted. The reality was that these were not even our very most unstable or chronically seriously ill participants. Most of them were transferred and are currently attending other ADHCs in San Francisco. If this is the outcome for our participants who have services in place and who have been more or less stable, can you imagine what the outcome will be for the others? Any transition plan must actually and adequately meet the needs of former ADHC participants who are at a very high risk for hospitalization or institutionalization, not theoretically meet those needs. Thank you.
Thank you very much.
Sorry for talking so fast.
Oh, not at all. We appreciate that you're talking fast, actually, because we still have one more panel. Are there any questions or comments from any of the members? I think Dr. Pan?
I know we're coming out short on time here. First of all, I think the most recent testimony we heard speaks to the importance of evaluation and knowing what happens to people, so they don't just disappear when we cancel the program. The other thing didn't touch on, but I know it was in the slide presentation from the director at the end. So one of the challenges is actually the issue of social isolation. And while certainly there may be other opportunities for these patients to have social interaction, I mean, there's a very large body of literature as a physician that I'm very familiar with about the relationship between social isolation and poor health outcomes. And so while that may not be viewed as a service per se, in terms of a healthcare service or a human social service or whatever else, it actually is very strongly associated with poor health outcomes. And I think we really need to, and perhaps we need to really look at that and the level of socialization people are getting. It's not just it's a very important aspect of quality of life, but it's also a very important aspect of outcomes. And it's often not captured because it's not considered a service. So I hope that whatever evaluation we're doing and we're looking at outcomes, we also look at the level of socialization that people are getting, because that may be one of the links that we see to if we see poor health outcomes as supported by currently in the current research on public health. Thank you.
Thank you. I think that's an extremely important point. As we continue to have these discussions, we heard from Mr. Hines' testimony that he could tell right away what the difference was before, during, and after the change in your family. So let me thank this panel again for your very important putting a face on this issue. And I know that some of our members have to excuse themselves, but I want to thank the final panel coming forward, Dr. Calvin Hirsch, who's Professor of Clinical Internal Medicine at UC Davis Health Systems here in Sacramento, Ann Hinton, who's the Executive Director of the Department of Aging and Adult Services in San Francisco, and Tony Anderson, the Executive Director of the ARC of California. I want to thank you very much for your patience, for being here for the entire hearing, which is going a little bit longer, but that just is reflective of, I think, the interest in this topic. And let's turn immediately to Dr. Hirsch, since I know being here probably required cancellation of some of your patients, maybe, or not. I don't know. I hope not. But I know that the doctors that come to testify sometimes have to make other sacrifices. So we thank you very much. Dr. Hirsch, please proceed.
Thank you very much for inviting me, and I'm glad we're doing it now because I'm becoming increasingly delirious after being post-call. So I've been up for quite a long time. Dr.
Okay.
Can relate. So I have prepared remarks
Yes.
that were distributed, and I'm not going to follow them. I'm just going to try to highlight certain key points, because a lot of the key issues have already been addressed, and I just want to bring those out. Dr. Pan made the important point early on that we need research, and the last panel very compellingly shows that we need to capture this kind of data. And if we don't have good data collection plans in place, it will be missed. And that really requires funding. It requires funding now in order to actually start collecting these data in a timely fashion. And it needs a thoughtful data analysis, thoughtful determination of variables. Don Perky brought home the point that these are complex, difficult patients with multiple medical, functional, and psychosocial problems who require case management. They require disease case management. What I want to point out is just a few key bullet issues of how adult day health really provides what I consider to be a unique service. First of all, we know that, just to sort of amplify what Dr. Pan mentioned, we know that not only does social isolation produce bad health outcomes, it does. Research has shown that it does cause institutionalization, and that's been shown very compellingly, and that adult day health care provides socialization. Depression in the client is also a powerful independent risk factor for institutionalization, not just the caregiver. Adult day health care has the potential for not only for recognizing depression in these clients, but monitoring the effectiveness of treatment. Doctors in the community don't do a very good job of detecting depression in older patients. We need a more sensitive way. Caregiver burden is a highly important risk factor for institutionalization, also demonstrated compellingly in the research. There's no dispute. Research has shown that ADHD caregivers, that is caregivers whose loved ones go to ADHD, compared to dementia caregivers, these are dementia caregivers, who don't have the option of ADHD, have a much less serious caregiver burden. And that's an important and hard outcome. So another point that has really come through is that we've been hearing about how we need to find ways of, in a sense, reassembling Humpty Dumpty once he's been pushed off the wall, and we're pushing them off the wall. Everybody has alluded to, well, we'll try to create ADHC-like institutions. Well, maybe if there are a few remnant ADHCs which amazingly have the wherewithal, financial wherewithal to hold on, that they could contract. We heard from the Department of Health and Communities and Department of Health Services that they're going to look to see, and individual HMOs are going to look to see how they can cobble together community services that will provide those. But this is very interesting. The whole hallmark of managed care is to provide coordinated care, and here we are telling them to go to fragment that care before. That's paradoxic, and that's silly. We are throwing I can go with all sorts of analogies, but we're throwing out the baby with the bathwater. This is ridiculous. So let me tell you a few things, review with you. I don't mean to be imposing things, but I'm trying to speed things along.
Thank you so much.
Of what's going to not be provided properly when ADHCs close their door unless they can be reincarnated in some way, shape, or form. Number one, respite. Respite care services are absolutely critical, as we pointed out, and we learned that unskilled IHSS workers are not going to be able to provide the respite. I mean, would we put our children and grandchildren in front of the TV with a teenage babysitter instead of a stimulating daycare center? Of course not. The same applies to our aging parents. Respite is provided very, very well. Case management, and this, I think, is a very compelling issue. Adult day health care is not just to delay institutionalization or prevent institutionalization. It is there to optimize functional status, improve quality of life, and to help provide unmet needs, and help to manage chronic disease. The chronic disease management is a critical area. You can get all of the case managers, but in ambulatory care, whether it's in managed care or traditional care, it's episodic. You can get these telephonic nurses from APS calling up, but I can tell you that they cannot change a wound dressing. There are a panoply of diagnoses that cause recurrent hospitalizations: CHF, COPD, behavioral problems. I can go on and on and on. These can be case managed by a person who sees them face to face frequently and predictably. That is not going to be replicated even in a managed care program, except maybe PACE, a PACE-like program, or SCAN, which basically is doing a large chunk of what ADHC already does. So another issue is rehabilitation. Well, we know that Medicare A and B cover, respectively, nursing home and home health rehab. But those are self-limited. Once a person has reached a plateau, they pull out. They're short-term. But a person needs to maintain their functional status. And the only program I know that provides maintenance functional status so that there's not a decline in deterioration, a major risk factor for institutionalization, is ADHC. And they do it efficiently. And what about nursing care? Well, people who go into nursing homes go for custodial care, but they go for transitional care and rehab. Having adult day health care present allows for potentially earlier discharge from transitional care. And for families that are a little tentative about bringing their loved one home and have been thinking about custodial care because they have marginal functional status. They all decondition after hospitalization. ADHC is that backup plan that may encourage them to try to bring the patient back to the environment. So I mentioned that it's sort of crazy to reinvent the wheel. ADHCs are perfectly suited to provide managed care for HMOs, and it makes sense in some way, shape, or form to have them formally collaborate, not to dissolve, but to formally collaborate where there are available HMOs. And we'll have to do and let that improvisation take place in rural areas like YOLO Shasta and Butte counties, where we are going to have to do something innovative to meet this diaspora of older people. So, integrating adult day health care or incorporating its services into long-term care is, it's back to the future. We're talking about the social HMO, expanding the whole notion statewide among non-senior HMOs of the scan or on-lock or PACE-like model. So let's do this. But as Dr. Pan has articulately emphasized, we need to do this in a systematic, thoughtful way, recreating or creating demonstration projects so we can collect outcomes data so we can fine-tune things. This is an opportunity for ADHC, in whatever reincarnation we want to call it, to refine and expand their goals, their their targeting of clients, people with chronic disease, recurrent hospitalizations, what have you, their assessment protocols, and their procedures. So we have an opportunity in the state, still saving money potentially, to do something right, but at the present time we're going to lose services without identifiable effective substitutes. Thanks.
Thank you, Dr. Hirsch. And I believe, are you not only, I think you are one of two of the geriatricians around the Sacramento region. I think I know both of you. You and Dr. Michael McLeod are sort of an endangered species, I think.
Well, I have to say that and I'm getting endangered by the day as I get older. I have to mention that there are two very capable family physicians in family medicine at UC Davis. And, there are geriatricians at the PACE program, at Posance, and at Mercy Hospital.
A few few more, and we're going to convert Dr. Pan by the time. By the time I'm done with this committee, he'll be going from pediatrics to geriatrics. So.
I'll teach him the MMSE and
yeah.
what the AFGAR stands for.
I should comment that when I was working in college, I did research in geriatrics.
Oh, okay.
Including looking at functional outcomes.
I knew that it's going to be there. Anyway.
Dr. Pan.
Yes. His son just started kindergarten today. So, all right. Let's turn now to Ann Hinton, who's the Executive Director of the Department of Aging and Adult Services, San Francisco. Thank you so much for joining us.
You're welcome. As the Director of the Department of Aging and Adult Services for the City and County of San Francisco, I am also the Area Agency on Aging Director and have responsibility for IHSS, APS, Veteran Services, all the guardianship programs, as well as the Community Living Fund, and, of course, we have an integration intake and screening unit for long-term care. As touch on some of the comments that you were making, as older adults and younger adults with disabilities live longer with functional impairments and chronic illness, our approach to chronic disease management has evolved, I think, to rely substantially on community-based services and less on institutionalization. The community-based long-term care report of 1998 identified chronic illness as illnesses or disabilities that persist for a long time, whether or not they cause death. Furthermore, that they are ongoing and not amenable to cure. They may range from mild to manageable to severe. However, chronic conditions are changeable, so prevention of actual episodes and maintenance of functional ability are primary goals. Communities across California have been addressing chronic care issues related to older adults through the services such as case management, MSSP, and linkages, although we've seen the demise of linkages in most communities and certainly the decrease of MSSP availability. Through IHSS, which we know triggers may be coming to us very, very shortly, and adult day health care. San Francisco has built and implemented its long-term care public policy blending these two things, traditional medicine and all these social supports. The San Francisco is home to Adult Day Health Network that serves over 1,200 older adults, and it's home to PACE. Because community-based programs have been so successful in our community, we have invested local dollars to provide services and supports to more younger adults and older adults with disabilities, specifically for those living at home who were really targeted to going into nursing home, as well as for those who've been in nursing homes for many, many years to come back out into the community. Our community is like many communities, faced with a lot of older folks who are that 85-plus age, and we know that 1 out of every 2 85-year-olds has dementia, and the 85-year-old population is the fastest growing. 3 years ago, San Francisco, through our department and health department, developed a diversion and community integration program that has, over the past 2 years, successfully managed the discharge of over 200 vulnerable adults from SNF care to community living, with 34% of those individuals needing ADHC to make their community living plan a success. We are now embarking on the implementation of the 1115 waiver and learning all we can from Maya and the folks in San Mateo and how they've integrated chronic disease management into their healthcare system. Specifically, how their integrated financing can provide a system of care that includes daycare, IHSS, and case management. San Mateo has the ability to purchase what is needed for clients, and that can include ADHC, as Maya explained today. But our county cannot do that in 60 days. Even though we have not been able to fully integrate long-term care into our acute and primary care the way San Mateo has done, we have been able to decrease the number of people going to nursing homes, and we have deinstitutionalized hundreds more. ADHC has proved to be a critical part of that success. Several months ago, as the head of the department, I convened a meeting of senior service providers to discuss what we could do in our community should ADHC be eliminated. We concentrated on adult protective services, IHSS, PACE, the social day programs, but also included those area agency on aging programs such as home-delivered meals, paratransit, and ombudsman. In the end, I concluded that only PACE and social daycare had the possibility of being successful for this client population, but both of those have their limits. There are only 200 slots available in San Francisco, and we have over 1,100 people in daycare. It takes we figured it would take years to enroll all those people because they're only enrolling about 5 people a month because the process that the state has impinged on people is so slow. And there is no financing mechanism for social day. So there you are. None of the other programs like home-delivered meals and paratransit and ombudsman have the ability to provide rehab and the medical oversight that an ADHC provides, which you already know. All the low-income people that are in ADHCs in San Francisco are already receiving IHSS. We do not have SNF or board and care beds to move people into unless we access beds in other counties, and I was told that by our ombudsman. We downsized our county SNF beds by over 300 so we could make a financial investment in community living. And that is how our community living fund was established. It's a $3 million fund annually, but it comes out of this idea that you decrease beds, institutional beds, so you can invest back into the community. Daycare, though, is a safety net for those who qualify for skilled nursing facilities. I have invested, as the head of the department, about $500,000 in social daycare programs this year, but it's not enough. There has to be a funding stream that is adequate and consistent. San Mateo has found a way. Would that the state would have taken the time to have learned from that experience before we were sitting before you today. Having run MSSP linkages, as well as being responsible for IHSS and established a social day program, I can tell you that the transition plan that's under discussion is inadequate because it doesn't get to the heart of what ADHC provides, which is appropriate health care and health care supports for seniors with chronic disease. And I want to thank Mr. Hines for being such a wonderful spokesperson for all of our families. The pictures of my family go before me. I'm sure the people that all of us know as well, but I really do thank you for being here today.
Absolutely. Thank you so very much. And now our final witness, last but not least, Tony Anderson, who's Executive Director of the ARC of California. Welcome, and thank you again for your patience.
Thank you. Thank you for having me.
Absolutely.
And good evening.
Yes, almost, huh? Only 4:30.
I am the Executive Director of the ARC of California, and our association is an association of people with intellectual and developmental disabilities and their families. And I also represent the United Cerebral Palsy in public policy matters through our collaboration. And it is a pleasure and it's an honor to be here today to insert some part of our conversation into this larger, broader issue. So I appreciate that. ADHDs have been a very important factor in making sure that many of our people are able to live in the community free of institutionalization, which is part of a long and dark history in serving people with developmental disabilities in California and the country. And also, in addition, though, to serving our constituents directly, it's a big part in supporting the family caregivers that you're hearing about, and in particular, the sandwich generation. So in our community, the sandwich generation, those who are caring for their parents and their children at the same time, it's actually more prevalent in our community than one might think. People with developmental disabilities tend to stay at home longer and live sometimes at home into their senior years. In fact, right now, over half the adults served under developmental services live at home. So the adults are still living at home, and it's just a common piece that happens. Another thing is that, with the aging, we have right now in California, the latest report on the state of the states is showing that 80,000 people with developmental disabilities are currently living at home in California with an aging caregiver. So it's not only supporting our consumers directly, but also our entire family. And Mr. Hines is a perfect example of what we're talking about. The life expectancy, for society is increasing, and unfortunately, too, for people with developmental disabilities, many of the disabilities are actually going to the same level as the general population. But what's really remarkable is that people with Down syndrome, who many, many years ago, it didn't make it through childhood. But fortunately, today, they're living into their senior years, life expectancy of 56 and beyond, the latest stats I've seen. Unfortunately, they're also experiencing early onset dementia. So it's another factor that's going into this whole picture. Right now, we only represent about 11% of the population served in the ADHDs. But that's 4,000 people, and to us, that's a lot of people. And I would say probably to everyone, that would be a lot of individuals that are served. So, and these are also people with very serious health care problems. And they're in a constituency group that is known to have the worst or the poorest health care outcomes of any other group that's supported through Medicare and Medicaid programs. So it's a very vulnerable population already. So before I highlight some of the problems, I want to at least acknowledge that regarding developmental disabilities, I think the administration has made some promising moves in preparation for this transition, at least in the budget area. We have a lot of questions about how things are going to work out. The managed care issue and the case management, how that's going to be up, because it's going to be really needed. But we're confident we can get somewhere with this. However, it's been our experience as advocates over the last few years with the major systemic changes that we've seen, especially in developmental services, that we've had varying degrees of success and failure, depending on where you are in the state and who you are and how that your experience is with your particular regional center. Every regional center, as you know, is a unique, it's an independent, it's a nonprofit regional center, and it's unique to its area. So things happen in different ways for different people, and we don't have a standardized response, which is good and bad, right? Also, the Lanterman Act is going to require an IPP. So any changes in the person's approach to support is going to have to be done through an IPP. And, of course, all the advocates and families and everybody will fight to assure that that occurs. However, there's no guarantee. There was funding put in place, so a lot of people think that maybe there's nothing to worry about because it was, it is an entitlement, and so there was an adjustment. However, that the money doesn't follow the person. So it's going to be an individualized plan, and we will see how that all pans out. But there are a lot of things that could go right, and a lot of things that could go wrong. And in that scenario, there are chances for problems. We are very hopeful that we will have that IPP process that we're all expecting, that individualized process for all of the 4,000 individuals with developmental disabilities, and that they will get a timely plan written up, and that the days of them receiving notice that their services have been eliminated and that's the way it is, that those days are over, because our department director has put out a directive that says you cannot change their IPP without their participation. So you have to have a meeting first before you can make any adjustments. And she was very clear on that, and we are going to stand by that. And while it's difficult to prepare for any hypothetical missteps, we offer that maybe requiring ahead of time, up front, that there will be a review. I've heard a lot of requests for an analysis of what happens to the whole system, but in particular here with the regional centers, that if we review the outcomes for the transition by the end of the year, then it might provide another balancing incentive here, because there are plenty of incentives that are in our system to save money. It's part of the Lanterman Act. It must be cost effective as well as individualized. But to balance that, those incentives with incentives to really make sure that we've got a robust and comprehensive planning process that we put up front, that there will be a review of how this comes. So there's a sentence, if you inspect what you expect, then you'll get it, right? So what we think is if you put it out there, right, meaning that if we expect people with intellectual and developmental disabilities to receive the careful planning and undiminished array of the types of services that they need, then the sample review will show in a year later that there was a seamless process, okay? There's no reason to think that the 4,000 people were receiving too much service. So in time, in the end of the year, it would not be logical that their IPPs would show a decrease in the services. So there were unprecedented cuts last year, as you know, in years just before in developmental services, all over, and it affects all of us. There were, in a variety of ways, there were these cuts, but this was not one of those intended cuts. We asked that every precaution and protection be put in place to prevent another unintended cut in our system.
Thank you very much. I think hearing your testimony, that there are some extra, well, I won't say extra, but additional legal protections for the community persons with disabilities that may not be the same for our seniors. I'm very glad to know that your 11% has this IPP process. But that same protection, maybe has to come forth in a different way in another time for those remainder of the ADHD population. We don't have that same kind of, I think, legal protection that people's services can't be changed without some due process. That's what the lawsuit's about. Any questions for this panel? Then I want to thank the three of you who have come to speak to us about, what the impacts will be expected for community stakeholders. And being now that it is 20 minutes to 5, and I've gone over 40 minutes of the hearing time, I did want to leave time for public comment. I believe Robert McLaughlin indicated that we had an accessible mic. Is that correct? And there's a mic here. But and I know that we can take it out to the aisle if necessary. Thank you very much. While this panel is being excused, let's invite public comment now, and I think maybe we'll take, several minutes to do public comment. especially for those of you who I know wanted to testify on a panel, but as you can see, one of the reasons we didn't is that we went over time already. So please welcome to the public comment portion, and please state your name, and please let us know what you have to say.
Ninimara.
Yes.
I'm from Yolo County. I went to adult day services and with my Perky, and when I went there, I was a mess. I weighed 130 pounds. I was still paralyzed, and I was on 3 different kinds of medications, and I'm mentally, emotionally, physically a mess. And because of the center and the staff, I got physical therapy, speech therapy, occupational therapy, and when I learned from them, I've been able to live a lot healthier and a positive life because of what they taught me and my family. I know I do this service is good, and the only thing I feel for is the families who and people who lost their services, because I know how hurtful and harmful it is for them as a people, individual. I want to work. I know I don't like being like this, but I thank God for outdoor services, and that's all I wanted to say. If it's not broke, but don't fix it.
Thank you. Thank you, Nooni. Well, I will allow a hand for Nooni, I think. This is Marcelo Mata, but as he says, most people call him Nooni. Thank you very much to you and your wife and everyone who joined you today. Next witness, please.
Chairman Yamada, and I'm sorry some of the other members
Yes, I'm sorry. But
have left early. First, thank you. I kind of wish we'd had this hearing back
before.
in May.
Yes,
You know,
I understand.
so much
Thank you.
water's gone under the bridge now, and I don't think we can bring it back very easily. I sat out here listening to this very frustrated. I want to just take a minute or two
Sure.
to tell you what you're not hearing about. What you're not hearing about is that the managed care plans are publicly and privately expressing a lot of concern about their ability to take on this responsibility. You're not hearing that the public authorities in the counties understand or have even heard of enhanced IHSS. The Department of Social Services doesn't know what enhanced IHSS is. What you're not hearing is that the MSSP sites and providers, some of whom are here today, have just undergone an 11% cut. They are laying off staff. They are not geared up to hire staff and take on this responsibility. And you are not hearing that the managed care plans are going to be tasked with providing services. You're hearing that they're going to do telephonic assessments from a phone bank. I know one of them has a big phone bank in Long Beach. You're hearing that they're going to do some case management, but you're not hearing that a therapist is going to be there to provide speech therapy. You're not hearing that a nurse is going to be doing blood sugar tests. You're not hearing that a therapist will be there to provide mental health services, or a specialist in dementia care will be there to help both a family member and a patient. Those are all being shuffled off to Medicare or to carved out services or someplace else. What you're hearing about is somehow we're going to put in place some new coordination function. And I am really worried about what we do when we have frail patients, like you've heard from today, being jitneyed all over their communities to 6 or 7 healthcare providers a day to get these services. Are they going to be spending 5 hours a day in a cab or a bus? Is the state going to pay for them? No. The reality is we're dismantling a critical function for some very frail people.
I agree.
And I don't know what we can do about it, you or us.
Well,
but
maybe we should
boy,
file
let's get our heads together and figure out something.
Maybe we should file under the violation of AB 32. How's that?
Something.
This doesn't sound very environmental to me.
I hope
going to 15 locations instead of having the 15 services located, right? So
yeah.
where's the lawyer?
I hope you will
Is our
impress.
attorney still here? Add that to your pleading.
Please impress upon
Yes.
your entire caucus what we are doing.
I will do that. Thank you, Mr. Passmore. Next witness, and thank you so much again for your patience.
Good afternoon,
Good
Madam
afternoon.
Chair, and thank you for allowing for this public comment.
Oh, absolutely.
Unfortunately, the other members aren't here, but
Well,
my
I'll
name is
follow.
Christy Hernandez, and I'm a policy analyst for Ultimate Health Services, and it's my pleasure to be here on behalf of participants. Our Ultimate is one of the largest adult. I'm going to read this just so I can just zoom through it. So, Ultimate is one of the largest adult day healthcare providers in California, and our service area includes Los Angeles and Orange counties. We offer a comprehensive array of services, including PACE, MSSP, ICMP, and primary care clinics, where patients can have a patient-centered medical home. I would like to discuss in particular what will be the challenges of the participants themselves. Initially, we are concerned for the largest concentration of ADHD participants located in Los Angeles, which, as mentioned earlier, would be 2/3 of the 35,000 or 37,000 participants statewide who will be affected by this elimination in our service area. And as the Department of Healthcare Services staff admitted on the ADHD stakeholder call, all services presently provided will not be available to these patients after transition. So we are extremely concerned with the adequacy of the current managed care networks and their ability to provide necessary case management, occupational and physical therapy services, as well as entire medical benefit for $60 per member per month. In addition, there's no adequate provision in the transition plan that addresses the need for daily supervision from a medical management point of view. This is a key component that keeps these fragile patients out of institutions and living in the community. For example, one of our patients, Gilberto, because of lack of access to dental care, developed an infectious abscess which traveled to his facial bones and eventually to his brain, leaving him near death. Gilberto is now massively disfigured and paraplegic in a wheelchair and bedridden, unable to care for himself. The ADHD program provides medical intervention on a daily basis, managing his medication, contacting his primary care physician for needed medical treatments, feeding him, and providing physical therapy and occupational therapy to try and rebuild his potential capacity to care for himself. The center also manages the depression of this 49-year-old man who once was a sole provider for his family. How is a managed care plan for $60 a month going to provide for everything that this man needs? This is just one of tens of thousands of people, young and old, who find themselves in true need of being cared for. So we ask that you sincerely address this massive challenge, the massive challenges from the participants' point of view, and that you must ensure that no one will be sentenced to their bed in an institution or worse as a result of eliminating this program.
Thank you.
Thank you so
very much for that compelling testimony. Next witness, and we have a copy of that, right? Yes. Thank you. Thank you. Good afternoon.
My name is Brandy Johnson. I'm with Home Instead Senior Care, and I am a provider for MSSP, a private contractor, for MSSP, SCAN, and the VA. And I will tell you, on average, our rates are about $20 an hour, so they could get 3 hours of service in their own home. So the state is getting one heck of a deal, and this is non-medical, not one professional licensed person coming into the home for $20 an hour. So the state is on the hook for at least double.
Thank you very much. Next witness. Thank you again for your patience.
Oh, thank you very much, Madam Chairwoman, excuse me, for your time and your enthusiasm for supporting the needs of all of the people that we represent today. I'm Dr. Barbara Porter. I'm the Program Director of Inland Empire Adult Day Healthcare. I'm also a psychologist. And one of the populations that sometimes gets overlooked in ADHC are the mental health folks. I represent in Riverside County, I'm one of those dots that's not congregated together. About 129 at last count of mental health folks. I have contacted my managed care, the two managed cares in our facility. The answer for them, for the mental health folks when we go away, is we contract with county and they get to go maybe once a month, once every 2 months. I know for an absolute fact, anyone who knows anything about mental health and the chronically mentally ill, you're not going to get a paranoid schizophrenic to answer the phone, let alone take their medications without having established a rapport with someone. You're not going to get somebody who's ultimately depressed who's going to either take their medications on time or is even going to get out of bed. What we represent are keeping people out of the psychiatric institutions. Unfortunately, when we go away, we feel like we're sitting on a time bomb and it's going to blow up in our faces. And I just hope that this population gets some services, because in my county, there is absolutely nothing besides a once-a-month check to the psychiatrist. And that's not going to hold these people. Thank you.
Thank you very much for that sort of additional insight into the effects. Good afternoon.
Good afternoon, Madam Chair. I'd like to add my thanks to you for creating this venue for us to learn and express some of our opinions. I'm Havard Staggs. I'm a commissioner and currently the chair of the California Commission on Aging. But that's not really the what I'm talking about. I'm a resident of Amador County, a very rural county, and one of the oldest in terms of the percentage of our citizens that are over 65 or 85 or whatever. In our 5-county area agency area, we had one ADHC facility. It went under in April, and one of the things about ADHCs, very few of them get enough money officially from Medi-Cal or any other source like that to really stay afloat. They spend a lot of their time fundraising, they go after grants, they do all those kinds of things, and to have this pulled out from under just meant that there were no more opportunities to do that. One thing to add to Mr. Passmore's list of things that we didn't hear, or we don't hear about, I didn't hear anything, any questions asked or talk about rural areas specifically, a little tangentially about Fresno, which isn't all that rural. And I'm just wondering if anybody is thinking about or wondering about what will happen to those areas that aren't managed care areas that did have ADHCs that have gone away.
Exactly.
And I'd just like to ask people to keep that question and hopefully find answers to that.
Thank you very much. And thank you again. This was Have Staggs, who is also the chair of the California Commission on Aging. So thank you very much for joining us today. Next witness. Hi there.
I think you know who I am, Rick Hodgkins.
Hi, how are you?
Hi, good to see you. I smiled when I, looked over here and saw you. I'll try to be as brief as I can. I hope the distinguished head of services in the city and county of San Francisco is still here, because I'm thinking about moving down there. Up here in Sacramento, it's just so bad. Okay, now for the reason why I'm really here. I'm actually surprised that I'm here. I just heard about this yesterday, and I finally was able to make it down here. I am blessed that I do not need adult day health care right now. I'm 33 years old. But here's where I want to give it a little twist. If I ever need adult day health care, I'm not going to be able to pay for it in the future. If I ever need it, I don't know if I'll be able to ever pay for it, because as far as I'm concerned, I'm always going to be in poverty. So as far as I'm concerned, as long as I could, if I can't get adult day health care, why stay alive? I just go to my doctor and say, look, I'd like a medicine to help me go to sleep, because it turns out even though I need adult day health care, I can't get it. Nobody in my family can pay for it. The state can't pay for it. You know, why stay alive if you can't live with dignity? That's what I'm saying. I don't mean I'm not, on one hand, I don't want to take my own life, but on the other hand, if I can't get the services I need to stay in the community, why not? And, with this CAFE, if it's going to be a scaled back version, it obviously won't be able to serve the people, it won't be able to serve everybody who needs adult day health care. What I'm finding out these days is not only, I understand the fact that you can't always get what you want, but now the reality is now you can't always get what you need either. Thank you.
Thank you very much. Thank you for your testimony. Next witness. Thank you very much for your patience again. Hi.
Madam Chair.
Yes, hi, how are you?
I wish we were meeting under better circumstances. My name is Chris Jensen, and I'm here on behalf of Resources for Independent Living. We're an independent living center that serves the disability population in Sacramento and Yolo counties. And this is a tragedy. It truly is, because adult day health care centers do let people maintain their dignity and live independently in the community. And we're really concerned that, in some sense, we're trying to close the barn door after the horse is already out. Once adult day health care centers are gone, it's going to be way too expensive to bring it back, if and ever our revenues increase, which we hope we do, but it's going to be too expensive to reinstitute them. So we're very, very concerned and totally against the elimination of the adult day health care centers. And I want to introduce Sandra Vining, who lives here in Sacramento, who utilizes services at an adult day health care center.
Welcome, Sandra. Ms. Vining, come on forward, and delighted to hear from you.
Yes, my name is Sandra, and I attend Health for All Daycare Health Center.
Oh, yes.
And I've been going there for a while, and I enjoy going there. And I get 2 meals a day. I get breakfast, and I get lunch. And I enjoy going there, and I would like to continue on going there. And I didn't realize this was going on. I heard that they were going to close the health care down, but I didn't really know exactly when. And so today I heard that they're going to extend it until December. So I had came to, voice my opinion about it. So I take my therapy on Mondays, and my doctor at Mercy Hospital recommended me for a electric wheelchair, but I'm not really able to get it right now because the budget cuts. So I would like for my advocate to, speak on that where I can, go ahead and, get it. So that's all I have to say.
Well, thank you.
So I would hope that they don't close the center down.
I would hope so too, but it's we're going to wait till that court case. That's about our only hope right now. And I know Health Care for All very well. Dr. Richard Ikeda, who was the founder of that organization, is a very good friend of mine. And he says he's keeping his doors open, so we'll see. Thank you very much for coming. Next witness. Thank you again for your patience. Hi, how are you?
Hi, good evening.
Oh, hi, how are you?
Rico, how are you?
Hi, Mr.
I'm Pat Billingsley from Yolo County.
Yes.
For the last 4 years, I've had the opportunity to work closely with both Dawn and her organization in Yolo County, and came today really to talk about two things. First, I wanted to understand what Mr. Douglas's plan was and how the transition is going to work. And what I think is clear is that there needs to be an initiative at the legislative level now to come back and deal with the veto that the governor has taken. You still have 20-some days of session left to take some action. I really encourage you to do two things. To consider looking at, first of all, is there an opportunity to phase this into segments that make sense? Toby talked about the fact that it looks like L.A. County, San Mateo are in pretty good shape to move forward. Maybe it's still going to be hastily, and maybe those recipients will be less served than if we gave them more time. But I can tell you the people at Partnership that serve our county certainly aren't in a position to do this. And this year, maybe even next year would be too soon. So if they could look at this, and what we heard in testimony was that a significant majority of the people that are trying to be transitioned are sitting in San Diego, San Mateo, and in L.A. County, move those now in December. And then allow the rest of the state to phase its operation and two things can occur. So we use up some of the $85 million that you've allocated to keep those operations still going in the rural parts of the state or those areas that just aren't being able to serve by one of the managed care organizations. And then secondly, that would give us time to understand what the impact to these 30-some thousand people are in those counties where they did implement. And from that insight, then you can make a more informed decision what to do with the rest of the state. So I really encourage you to take the lead or to work with your colleagues to take the lead to initiate some action, because I think we've heard compelling evidence today that there is, in fact, a need to do something different than what we're about to do. And if I, as a private citizen, can be of any help to you, please call on me. If I can be of service to any of the agencies that are here, I'd be more than glad to help. This is really a compelling argument for listening to the physician. Doctors typically don't talk about things being oxymorons, but that's really what we've got here is we've got a situation where we're kind of going backwards instead of forward. So thank you for the opportunity. I appreciate it.
And
please
again,
call on me, Mariko, anyway.
Pat Billingsley, who's a longtime friend and colleague. Thank you very much for coming. I didn't see you until just now. So, next witness.
Good evening, Chair. Thank you so much for giving us this opportunity to hear from expert witnesses as well as to provide some input. My name is Debbie Toth, and I work for Rehabilitation Services of Northern California. We're in Contra Costa County. We have an MSSP as well as 2 adult day health care programs. We're 2 of 3 in Contra Costa County. I have from the Multipurpose Senior Services Program Site Association a response from MSSP that I'm going to
just give to the sergeant.
Yeah, and actually there's another MSSP site director who's going to speak about MSSP in a moment. So I'll focus on adult day health care. I too am saddened that we're having this conversation now, but we are. I'm glad we're at least having the conversation. I wanted to point out a couple of areas of particular concern and areas that I think are not being really well thought out. Not that much of this is well thought out, but some areas of interest. So the idea that I heard today from Mr. Douglas that this $60 is not a definite amount of money that we're going to figure out exactly how much money. Right. So first I've heard of that, but then to follow that up with we're going to give however much is necessary to provide these services. I have to say we're talking about adult day health care like services, and I think in some cases their hope is to contract with adult day health care centers that keep their doors open. Well, those of us who keep our doors open because we're nonprofits and able to get grants and beg for money and do whatever we have to do to scrape, beg, borrow, steal so that we can keep our doors open, our services are going to be more expensive because we're losing half or more of our census.
Exactly.
So when they talk about saving money, that's a joke. And I do want to make public record that I find a comment that all of the letters are sent out in a low reading level very offensive. Many of the people that we serve are doctors, politicians, lawyers, very people who are wealthy in their hearts, their minds, their spirits, and their contributions to our society, and I take exception to that comment. When talking about the transition plan, sorry, back to that, the IHO slots, 1,000 slots, is going to serve 37,000 people, and I want to point out the fact that he says it's cost neutral because you can't spend more in the IHO waiver than the cost of what you're currently spending. Yet what services are you going to purchase with adult day health care if, as I said previously, it's going to be more expensive? They referred to PACE and SCAN as being a full array of acute and long-term care services. PACE, as we heard from Tracy's testimony, of their 72 people, 2 people qualified for PACE out of their program. I don't think we're going to see a lot of that, and they do have that full array. However, I will argue that SCAN does not. It's a social HMO. It does not have adult day health care centers that are a part of that plan, so it's not a full array of services. I'd also like to point out that we don't know as a public, we've looked for the information, how much does it cost in their contract with APS per assessment that they're providing, and how are they going to accurately estimate the cost of that when they don't know how many people are going to positively opt out of this supposedly optional managed care enrollment. And the DD population where we were talking about, again, they have this pot of money. They were set aside, I think, $30 million so that they could have services for them. But if there are no adult day health cares around, or if it's more expensive, again, how are they going to purchase that service? And finally, just to put a human face on it, because we've heard a lot of really, really incredibly sad stories here today. I've been brought to tears multiple times. I have at my program an Alzheimer's Daycare Resource Center, a Russian program, a general program, and a Farsi-speaking program. Our Farsi-speaking program is predominantly women who came from Afghanistan, who lived through the Taliban to watch their sons and husbands murdered in front of their faces. We are not required by Title 22 to provide 3 hours of counseling in Farsi every week for these women, and we do. Where else are they going to get that and the will to live?
Thank you very much. Next witness. Hi, Lola.
I'm Senior Senator Lola Young with the California Senior Legislature. And you heard Miss Mitchell talk about an aha moment in this whole ordeal. Well, my aha moment came just a couple of weeks ago, and it wasn't the governor's veto. My aha moment came when a friend of mine called and told me that the person she was caring for was incoherent, and please get over there and help her right away. Well, when I got there, her brother Dashiell was in the room, and he was incoherent, and I sat with him patiently to try to get what was wrong. I finally determined that Dashiell had taken 7 Tramadol. He had been saving them up. So, of course, I told Tina to go ahead and call 911, get him help right away. And we got to talking, and I asked Tina about what had happened, what would cause him to do this. Something had to happen. The only thing that had happened that week was that Dashiell had been notified that his adult day health care center was going to close. Now, we're talking about EMT services, emergency services, 72-hour suicide watch, and now Dashiell is in an institution. Somehow, I don't see the savings. And this is just one man in one neighborhood. We're talking about 3,500 people. That's a lot of people. And besides the money, it's a lot of lives.
That's right.
And you heard Hodgkins. It just touched me when Mr. Hodgkins said, if you can't live with dignity, why live? And after the experience I had just this last week, you can imagine how it touched me. He might have been trying to be dramatic, but I can tell you it's not dramatic. It's true, and we need to take that in consideration. We're not just talking money here. We are talking lives, and we need to bear that in mind.
Thank you. Thank you, Senator Young. Next witness, another good friend, Frances Gracechild. See, I get to see you, even though this is tragic discussion, I get to see all my friends
It is a special pleasure to see you. Remind you, I now live in your district.
Yes, you do. So I have to behave.
You've got to get those lawn signs out to
now.
my place in time.
Oh, boy. See,
You know, I've been listening to all the service tigers and the consumers, and like the wonderful woman who spoke. I'm sorry, I don't know your name. About the Afghani women, that they provide services in languages that are unrequired of them. It makes me think about what's really so unique about what we're about to lose is that this is a high-touch service. We don't have a lot of high-touch services. People, you get to go somewhere every day and have breakfast with faces that become your friends, be they staff or other consumers. And it's a safe place. They tell each other jokes. It's the quality of life that makes life worth living, are these relationships that are built there. And I know you know this. I would not dare to preach to you because I learned most of what I know from you. But I
Like
do
what?
feel like it's my job to be here, even though my staff did an excellent job of speaking up and our consumers were here and do a better job than I do. I think I did isolate one thing that I noticed that I didn't know until I was here today, and it just came to me, that probably the most dangerous thing for people with a high level of disability and needs and chronic illness is change. Change is almost uniformly like the banana peel that is in the room that will cause the problem. Like people lose, I'm not going to the daycare center anymore. Just that anxiety can set things in motion that will cause to have to go to a higher level of care. So I really think while it sounds anecdotal and maybe nicey nice, dramatic, I think it really is the critical piece of what adult day health care centers provide. Then the last thing I wanted to do is I kept thinking if Joan Leon was still here with us, she would be so mad today.
Yes.
Yeah, Joan Lee. That's what I meant. Did I say Leon?
Well,
there is another
maybe
great
she-
Joan, and her last name is
Leon.
Leon, but it's not the one I was thinking of. No, I'm thinking
No,
of Joan
Joan
Lee,
Lee,
who passed,
absolutely.
and Robert Adult Day Health Care Center was her baby, and she would expect me to get up here and pitch for
Yes,
her.
she
So
would.
I'm pitching for Joan.
I've been feeling her
Have you been-
presence, since I took that vote.
And the last thing is, of course, thank you, Mariko. How come you get all the easy jobs around this place? You're going to have to be, the little engine that stops this train wreck, and I'm betting on you.
Frances Grace Child, you are one of my role models, and remember she took on a tough race
Oh, dear.
in this building as
That's
well.
the race that won't die.
That
So
was
don't talk about
no,
it.
that was a very gutsy thing, and I've learned a lot from you. So thank you for being here. Thank you for your testimony. Next witness. And thank you for all of your patience back there. Yes, ma'am.
Hi. My name's Catherine Stambon. I work for Lifelong Medical Care, and I'm all choked up because I just can't even believe that we're here and we're having this conversation. And
Well, without the veto, we might not have, but maybe it was an important conversation to have anyway.
well, that we're here at this point and so close to elimination, and I feel so blessed to be part of such an amazing community of providers. And I just have a few comments on some of the testimony that I heard, and I'll be quick. The department suggested that ADHCs will be able to help people pick their managed care plans, and that raises an ethical dilemma for me. If part of the idea is that we'll be contracting with those managed care plans, there's a financial incentive there, and it's just not, we can't be part of that, I think.
Good point.
I also wanted to comment, the department trotted out the San Mateo health plan, and they're great, and they are so far ahead of other places in the state in terms of care integration. And I feel like, maybe they're the example of what we're moving towards, but we're not there yet. And that's part of what the duals pilot is about, is sort of getting us moving in that direction. And adult day health care needs to be part of that duals pilot, and that's starting in the fall. And how are we going to hang on until the fall in order to be part of that and move forward constructively together? Third, I have kind of a question, and this is really more for the department, but I want to put it out there for the record, which is the transition plan talks about current ADHD beneficiaries moving into managed care and current ADHD beneficiaries becoming eligible for these expanded waiver programs. And what about people who've already lost their ADHD because their centers have closed, or people who might need the service next year or the year after that? What is the plan for that? Are managed care plans going to get an increased capitation? How will they identify those people? What about the people who aren't lucky enough to be in an ADHD now, but they're at that same level? Will managed care plans get an increased capitation for them? How is that going to work so that there's some equity in all of this? And then finally, I just wanted to make a comment on this $85 million, and I feel like it's just laughable to think that there's going to be money left for services, because I just did some really quick math, and July to November, that's 5 months. If it's $14 million a month, which is what Mr. Douglas said, that's $70 million spent.
right.
than if, say, 30,000 people end up in managed care. $60 per member per month times 7 months, $12.6 million. So I'm at $82.6 million already. I haven't increased anybody's IHSS. I haven't added anybody to any waiver programs. I haven't paid any for-profit New York-based care management companies. So where is this money going to come from, and why didn't we just stick with ADHD in the first place?
Well, and we lost $85 million in federal match as well, which is just astounding that we would leave any federal money on the table for any reason.
Hi.
Thank you. Welcome.
Thank you for doing this.
Sure.
My name's Jill Youngling, and I'm from Eschaton's Adult Day Health Care Center. And I have screamed and yelled at every opportunity that I have had about the elimination of adult day health. Today I'm not going to scream and yell because my energy is just gone. I do have some responses to some of the testimony. I heard we are going to be moving patients here and we are going to be moving patients there from our friend Mr. Douglas. And I'm just wondering what happened to patient choice. I also heard the comment that there's been coordination with the Department of Aging. I think I've received 2 pieces of correspondence from the Department of Aging telling me of our mandated requirement to prepare a discharge plan. I don't think that's coordination with the Department of Aging. Also, I heard that everybody, all these different agencies are going to be performing care plans. We already do an exquisite job of care planning for folks with qualified professionals that know them. And the care plans, I don't care who in the heck is making the care plan. This is not about the care plan. It's about the services. And we can have care plans, and if nobody's providing the services, who cares? My last one is, how is this voluntary enrollment in managed care? That's the most asinine thing I heard here all day, is that you force somebody to do it and you call it mandatory, or you call it voluntary because they can check out of it. You remember the good old days when you used to order CDs, and you'd sign up, but they were going to send you 20 free ones, and then you could opt out of it, and you'd try for years to get out of the damn arrangement. And this is the same kind of stuff. So thank you very much.
I like that. That's a good one. That's excellent. Welcome.
I had one of those plans. My name is Michelle Pope, and I'm the Executive Director for Alzheimer's Services of the East Bay and Alameda County. We have 3 centers, and we serve 120 people a day that are diagnosed with memory loss, dementia, mental illness, and then all the other things that you've heard about today. My colleagues have already asked some of the questions that have been on my mind, so I'm going to speak from my heart. I am very concerned about a state that will let this unstoppable train go without the courage to say this can't be done. This is not right. If these were little babies and they were in danger, we would all be running out of this building to protect those babies. I'm a mother, so I get that. But because they're seniors, or because they're underserved, or because they're GED education, or because they cannot come up here today, the caregivers, because they're working really hard to try to keep their family member in their home, in their community. Do we have the right morally to turn our backs on them at a time when they need us the most? I don't make a lot of money, but you could take a little bit more tax from me and stop this from happening. I would give up everything to see those 120 people that I serve on December 1st continue to walk through my doors. There's 45 of them that there will be no door to walk through because we have already decided to close one of our centers. I have to be the one to be in the room with those caregivers and those folks who are demented and don't even know what is happening to them, to tell them. And then what happens? Okay, plans are great, but what happens the day after? It's always the day after that we refuse to talk about. And as Assemblywoman Mitchell said, let's have the courage to speak the truth, because only from the truth can we have a solution. And we need to work together. No one has come to Michelle Pope and asked me a doggone thing about the people that I serve. And I've had to come up here to tell you.
Yes, ma'am.
So I just say, I don't know what can be done, because I also was a policy major, and I know there's certain legislature you can't change once certain people push a button and crap happens. But we're talking about people. We're talking about people. And as a mother, I want my children to understand that, yes, they should go to college and they should contribute and they should be a part of a society, but I shouldn't be the only one teaching them. All of these people teach them, and so do all of you. So I just thank you so much. You and I have shared a mic together not too long ago.
Right.
So I thank you for that opportunity. But just, we got to have some heart here and not just be making policies that murder and kill people. Thank you.
Thank you, Ms. Pope. Thank you very, very much. Make sure Robert gets your contact information, because we're going to have to share some more microphones. Girlfriend. Okay. You got it. Okay. Yes, sir. Thank you.
Yeah. My name's Richard Strange. I'm the site director for the MSSP program for Napa and Solano counties.
Yes. Welcome.
Thank you. I really appreciate you taking the time, not only for the hearing, but also to listen to what everybody has to say.
What we're here for.
And not everybody does, and for me, this is emotionally very, very exhausting, and it must be for all of you too. So I'd really appreciate it. It's as the MSSP program just heard recently, like everybody else did, that we're talking about more slots, and we're just trying to figure out exactly what that means. It's complicated in terms of how. We have pages and pages of questions that I won't inflict upon you now, but so many questions are raised by some of these solutions that it's really going to take some time to even make any sense of it and to figure out whether or not it's practical. And sometimes, as mentioned before, that we just went through an 11% cut, and one of the things we were told in that cut was, well, you can't disenroll people from the program because you got a budget cut. Because MSSP clients are nursing home clients as far as the federal government's concerned, and so you'd be kicking them out of the nursing home, and you can't do that. And so as MSSP sites, we're very concerned about how big we get, how many new clients we take on, whether the funding will really be there next year. And really how we can operationalize this. I think the MSSP site directors are all hopeful that we can be part of some solution here, but there's still very, very many questions to deal with. One of the frustrations for me and for others has been an apparent lack of understanding about the aging network and the various programs and the different roles that they serve. And I see there's this energy to sort of patch this hole. We're going to eliminate this program, and let me throw this in. This was sort of strange, surreal for me being here. It seems like it was only a couple of months ago we were here arguing to not eliminate MSSP, and now we're the cavalry. I mean, it's a strange thing, but it just speaks to the whole complexity of this, I suppose. But it would be maybe politically expedient to say, well, we're going to eliminate this one program, but we're going to fill the needs by expanding some of these other programs, and everything will be fine. I think a useful analogy, it's simple, doesn't involve babies or bath water, and it's not patented, so feel free to use it, is really more of a jigsaw puzzle. And each of the programs, each programs are different and only really fit in one spot. And when one's gone, you can't fill that with the other pieces. And in recent years, and I'm not suggesting that the puzzle has been a tight fit and that all the needs have been met. I think we've been a loosely fit puzzle. I work very closely with the ADHCs in Napa and Solano counties, and they refer clients to us. We refer clients to them. We also work closely with in-home supportive services, and none of us are under the illusion that we do each other's jobs. We all have very specific and different roles. And I don't think that's been very well understood. I know you understand it well. I don't think that's been very well understood in Sacramento. And I think it's really, really important that the legislature understand that there is no filling a hole. And I'm so glad that Assembly Member Mitchell pointed out that there's going to be no facility for these clients to go to during the day. And for most of the folks that we have that are in ADHCs, they've got family members who are, maybe they're able to go to work. And not anymore.
Right.
And even though they're in MSSP, there's nothing I can do to fill that hole.
Well, let's keep, making that statement, because it's only when the non-traditional partners, I think, come together, the business community, the emergency services community, that are going to be called by 911, much more frequently. It's going to have untold effects. So we'll continue to have that conversation. Whatever that list of questions are, please give them to us.
I think you may have it already.
Okay.
If not, I'll make sure you get it.
Thank you very, very much for your testimony. And John Troidel, I get to see all my friends, like I said. How are you?
Well, as you and I both know, I'm your constituent.
Yes, I have to behave myself.
Yes, and you're representing me very well today.
Well, thank you, Mr. Troidel. Thank you very much.
Oh, you're welcome. And I'm speaking personally. My dad our whole family was involved with an adult day health program in Mountain View, close to where my parents live. And for him, the service was tremendous. He had diabetes, Parkinson's, a sequelae of prostate cancer. So the services were absolutely necessary. And it was a huge help to my mom and the rest of us. And when I told Mom about the hearing,
she said, "You better go, huh?"
Oh, yes. And she wanted to acknowledge a social worker, which I thought you might appreciate.
Well,
a social
thank
worker
you.
named Jim, who was so helpful.
Very good.
Because my mom is deaf, and he made the phone calls for her.
Thank you. Thank you. Thank you very much, John. I did not know that your father was a consumer of adult day. That's great. Thank you. Welcome.
Thank you, Assemblywoman Yamada. My name is Donna Wilmot. I work at Planning for Elders in San Francisco. And sitting here listening to this very eloquent testimony all day long has been, or all afternoon has been very sobering. And I probably, like many people here, have this feeling like I'm watching a train wreck about to happen. And it puts me in this frame of mind to step back and think about how this decision got made in terms of budget priorities. And to the extent that a budget tells us what's important in any society, this budgetary decision is a disaster. It's saying that the lives of seniors and people with disabilities are not as important as other people's lives. That's really what it's telling us. It's also telling us, as someone else earlier said today, it's like every elder and frail Californian is now on their own. I mean, it's really stepping back from what's our social responsibility. And I just feel like this is one of those moments in time where we have to get back to really what's important and what kind of a society do we want to live in. And I want to live in a society where everyone has a place and has support, and where a place that we can be proud of, that people's lives are respected and they will be part of the community no matter what their level of physical health or mental capability is at any given moment. So I thank you again for having this hearing, and I hope that there's something that we can do to stop this train. Thank you.
Thank you. Thank you. Next witness, Randy.
Randy Hicks,
Yes,
Californians
hi.
Disability Rights. We would like to echo all the sentiments that was said by DRC in their lawsuit there. We totally agree with everything that they say about this. One of the concerns I have about this is IHSS, the In-Home Support Services. I'm also on the coalition. We've been talking about how they want to do quality assurance, which is to level out the counties. 2, they want to look at hours. They said they want to reevaluate hours. Reevaluation, doesn't that really mean cut? And 3, they're always taking a look at lowering the pay. I can't tell how many times that they decided to make IHSS workers do minimum wage. They don't have minimum wage in bills, just to mention that. Plus, the quality of care comes from how well you pay your workers. That's why in the IHSS coalition, which I'm a member of, we have very great concerns about the closing of adult day health care because not all IHSS workers are skilled, trained workers to do most of the things that ADHC does. And so you're spreading your workforce too thin in order to cover a program that's always covered a lot of Californians, even 35,000. You can imagine where those 35 are going to go. Just like Ms. Mitchell said, we need to have a comprehensive program to make sure that nobody falls through the cracks. And that possibly will happen because you can't cover everybody because not everybody can be in a program. Thank you very much.
Thank you, Mr. Hicks. Thank you very much. Next witness. Hello,
Hello
Burns.
there.
Hi, Burns.
I'm Burns Vic, and first I want to thank Assemblywoman Yamada for your incredible patience in bringing together this group, and I assure you agree you have competent staff, and that really helps too. I appreciate that.
Yes, I do.
I also want to thank Lydia Missalides for all of her hard work on this. I really respect her. I want to make 2 comments and a suggestion. As I was listening to the department's presentation, I realized that you had 2 pretty distinct examples. One from a county organized health systems agency, San Mateo Health Plan. I happen to be a big fan of Cal Optima, which is, along with San Mateo, has a really good proposal in on long-term care integration. And then the 2-plan model, one of the representatives. I personally and professionally am a big fan of the county organized health systems agency model because you don't have to worry about profit making in shareholders. And so the money that's saved or the money that can be redirected or where a COHS can actually move money around, I think allows them to provide services others can't. And so I just want to urge you to take a close look at that and the proposal that's in. The recommendation I have in listening again to Toby and others, and the questions were very good about how do we follow up and find out what happens to people. So I would urge that since you don't have an election year, thank goodness, you have an interim here, that the idea of having several of the other committees do some joint hearings is excellent. And I think to the extent that Ms. Mitchell, in her capacity with you, can take a hard look at some of the financing and the way in which the different plans are financed and how that translates into tracking clients and seeing what happens to them. So thank you very much for your patience, and I appreciate the opportunity.
Thank you very much, Mr. Vick. And Marty Omoto, who needs no introduction.
But you just gave me one.
Welcome.
I actually wasn't going to say anything or speak because I think all my friends and colleagues said it just as well. But so many lives are being broken and harmed, and not just the people who receive the services, it's the families, it's the workers, it's the providers. And I just felt compelled that I couldn't just sit and listen. I just had to say something very quickly. And really, and I want to say this out of total respect to the Department of Healthcare Services and the other departments. And I have great respect and work closely with Toby and Mark and everybody else there. So this is not a reflection to demonize them, but a mistake was made. And at the end of the day, I think we have to, after listening to all this, listening to the stakeholder meeting last week, is there a problem? Not going on whether or not eliminating adult day health care was the right thing to do or not, but is there a problem now? And I think if you heard everything, the testimony, whether it's from the department or from stakeholders or advocates, there's an agreement. There is a problem. And so it leads to the other question, how do we fix it? And I don't believe a good answer is that we wait for a lawsuit to decide the issue. I think the responsibility on all of us, whether we're advocates, family members, recipients, state people or legislators, that we have to do something to correct it. We're not talking about undoing what was done. You can't do that. But we can correct a mistake. And if any one of you, any of the legislators tell us that you can't correct a mistake, then why are you there? The whole purpose of a legislature is to provide remedies to mistakes. Here's some questions. And this is not hindsight. It's not hindsight when people are being warned of things happening now or things that can happen in the future. So this is not something that we're whining about that happened 6 months ago. The decision was made. We think it was wrong, but the problem now exists, so how do we fix it? Here's the question. If other services, if people can be referred to other like services now or in some way, then why is there a need to eliminate adult day health care? If you do the assessments and you can refer people to cheaper or better services, then that will take care of the cost issue of adult day health. Number two, the plan itself, again, this is no reflection on the good work and the good people at the department, but the plan needs to be more specific. It's 22 pages, of which most of that, or half of that, or nearly half of that, were attachments. And there's not specifics on where these people would be going to. Assemblywoman Mitchell said it correctly. It's not so much about the outreach or where we're going, but where are they going to? What was the reason? Here's another question. What was the reasoning by the department, and they gave it, but I'm just asking rhetorically, what was the reasoning to delay the effective date from September 1st to December 1st? And the reasoning is the state was not ready. However, in June, or before the legislature voted on the budget, the administration was claiming the state was ready. So what changed in less than matter of a week or two, that the state realized it was not ready? And why is December 1st better than September 1st? And our response to that is, I think there's agreement that the state of California is not ready. So why are we doing this even on December 1st? And if the state has the power, without the legislators to approve it, to delay it, then delay it further until we can get the proper transition and the proper elements of a plan done. That's something the legislature can actually require the administration to do if it has the political will and the desire to do so. And also on the money issue, I heard it said that each month of delay costs or costs the state $14 million. That was true when Governor Brown zeroed out the adult day health care budget originally in January. For those of you who may not realize, originally Governor Brown wanted to eliminate all general funding for adult day health effective July 1st. But in the May revise, the governor allocated $25 million, and the legislature upped that back up to $85 million, and the Department of Health Care Services committed to an ongoing appropriation of $85 million for several years to help with transition and to help with moving people into new models of adult day or other services. So there is no savings, at least not the savings that Toby was talking about. Lastly, here's some recommendations. Oh, and here's a question. Why aren't workers and why aren't community-based providers included in the transition? It breaks my heart somehow that the state of California and the legislature and the administration, you guys are all good people, but why is in discussion, for some reason, the lives of the people who provide these services, who pay their rent, who have to face and go home to their families and are in the threat of losing their health care, losing their homes in their own communities, and that's not part of this discussion. It should be paramount, along with the people who are receiving the services. Because we can't treat people with more dignity than another, in our advocacy. Here's some recommendations. I've said this before. The state of California understood that in the previous years, in the 1990s and 1980s, that it proceeded in the wrong way of hastily closing developmental centers and state institutions. As a result, it passed state laws that required the state of California to proceed in a very deliberative manner before it closed a developmental center. Roughly a 2-year process, but it's actually longer than that. It was done not just simply to acknowledge the budget savings that would be necessary to be achieved, but it was done because of the health and safety considerations, because people's lives were being threatened. If that is being done or was done for Agnews, and that took 6 years to close, by the way, we're talking about less than 400 residents and less than 1,600, 1,800 workers. And it's being done for the Lanterman Developmental Center in Pomona, which has less than 400 people and 1,600 workers. Then why aren't we applying those same values and principles in California state law to 34,000 people who receive services and 300 community-based organizations that employ 7,000 workers? What am I missing here? Number two, require that the state of California, the administration, convene regular stakeholder groups that include representatives of the legislature, includes representatives of the advocacy community, on a regular basis, not only to receive information, but to participate in decision-making or at least implementation. And that's something the legislature can require. Require that any plan of implementation and transition include the community-based organizations and the workers. And lastly, the transition plan needs to be fleshed out. I mean, seriously fleshed out. Again, I know that the department has limited resources, but so do we. Lastly, in terms of savings, I just think it's kind of adding insult to injury to the community-based providers who are not exempted from the 10% Medi-Cal reduction. Right. They're not exempt from the 4.25 payment reduction through the regional centers, and they're doing that being told that you're going to be eliminated December 1st. And I just think that if we're going to proceed with elimination and through a transition process, then somehow the providers need to be recognized and be compensated appropriately, and certainly need to be exempted from any payment reductions. Mm-hmm. Hemingway wrote that everyone is broken by life and that some are made stronger in the broken places. But you're looking at an audience of people who have been broken by life, and the adult day health centers have helped, made them stronger. But with this proposal of closing them down in the way that it's proceeding, people's lives are being broken. And I don't think it's the rhetoric. You can look at people's faces. It's not about just saving jobs. It's people's lives are being broken. And so the challenge to all of us, because it's not just to you, it's to all of us in this room, is, well, what are we going to do about it? The question is, at the end of the day, is there a problem? And the answer is, yes, there is. And the next question is up to all of us. Well, what are we going to do about it? Thank you.
Thank you. Well, as only Marty Omoto can summarize a hearing like this today, being at the hour is 20 to 6 p.m., I want to thank again all of our staff and our sergeants for helping us manage today's hearing, all the participants. Assemblymember Mitchell asked, where is this transition? I don't know how many of you had the opportunity to read something that I quickly penned in advance of this hearing called California's Adult Day Healthcare System Transition to Nowhere. It really just speaks to the fact that we know that at a time when our population is peaking for this very age group that we are all hopefully going to be a part of, when we know that we have a population of people with multiple chronic conditions that are essentially being cast out without services, without certainty. It's nice to try to hear what the administration has to say, but I will certainly be the first and not the last to say that there is a major mistake that has been made. And as I believe Lydia Maslides said earlier, a humanitarian crisis of our own right here in California that's about to unfold before our very eyes. And I think it really is incumbent upon all of us on both sides of the aisle in the legislature to try to raise this issue again to the highest levels and see if there is something we can do. We do hope that the legal proceedings are successful. I will go on record with that to say that, again, that is the only branch of government that seems to be making any sense these days. But you're also struggling with a $350 million cut to the judicial branch. So let's just conclude. Conclude by, again, thanking everyone. I know that Lydia Maslides had some recommendations. I hope that she will share them with us. And we will continue this conversation, hope for additional hearings in the near future. And thank you all so very much for your patience and participation. Thank you.